computer audio, there is no need to enter an audio pin. A handout of the slides is available for download. Just open the Handouts pane to access the file. And this webinar is being recorded for future posting to our policyholder website, My Account. This program has been designated for a maximum of 1 CME credit, and you should only claim credit commensurate with the extent of your participation in the activity. Just to let you know, this program is also being jointly provided with MedResults Network, and just wanted to welcome those of you from MedResults Network who are participating today. To get CME credit, you must complete the evaluation and attestation survey. A link to the evaluation and credit attestation survey will be provided to registered attendees in an email within 2 hours or so of the closing of the webinar. If you are watching this webinar with a group, the registered attendee should forward the email link to other members of the group. And if you happen to be using another registered attendee's sign-in link, just know that you won't receive the email either, and that you'll need to ask that it be forwarded to you. The information contained in this presentation is intended as risk management advice. It does not constitute a legal opinion, nor is it a substitute for legal advice. Legal inquiries about topics discussed during this presentation should be directed to an attorney. The faculty and planners of this activity have no relevant financial relationships to disclose. Our speaker, Jody Thompson, is a senior risk management specialist for NORCAL Group. She worked as a cardiac ICU nurse and now has over 20 years of clinical and healthcare risk management experience. Jody assists policyholders through phone consultation, presentations, resource development, and on-site practice assessments. Now I'm going to hand off the presentation to Jody. Just one moment here.
Thank you, Shirley. Wait for my screen to come up. There we go.
It's all yours.
Okay, well, thank you again. Thank you, Shirley. And welcome everyone to today's webinar on using teamwork and communication in your practices to minimize professional liability risk. The learning objectives for today are to assess your practice for key risk issues that may contribute to professional liability claims, and to apply risk management recommendations that support patient safety and increase defensibility in the event of a claim. While this is a risk management program, we'll start by touching briefly on the elements of negligence. There are 4 elements needed for a medical negligence claim to go forward. First, that there was a duty to provide care to the patient. Next, that there was a breach of duty or a deviation from the standard of care. That there were damages or an injury suffered by the patient. And lastly, that there was causation, meaning that there's a direct cause and effect from the breach of duty to the patient damages. And the patient's or the plaintiff's attorney has the burden to prove all 4 elements in order to prevail. So the hope with this program today is to offer risk management suggestions that would help prevent these claims from occurring. So we're going to talk about these 4 common risk issues that we see in medical practices. Supervision and collaboration with advanced practice professionals and nurses, medical assistants and their scope of service, informed consent, including providing realistic expectations and making no guarantees of results, and medical record documentation. So we'll touch on these key risk issues of each of these topics, and I'll share a few case scenarios and provide risk management recommendations. We'll start by talking about advanced practice professionals, or APPs, specifically physician assistants and nurse practitioners. Let's take a quick poll. Do you have advanced practice professionals performing aesthetic procedures in your practice? And Shirley, I think you've got the poll opened.
Yes, you can see that it's been launched. And Jody, we're just going to wait for the results to come in. So I'm just giving everyone a chance to enter their choice. And it looks like we have a majority of the responses. Okay. So let me go ahead and close this poll for you and share the results.
Okay. It looks like the majority of those who responded said that they do not have advanced practice professionals. Some do, and there are some in attendance that are advanced practice professionals themselves. So whether you are an advanced practice professional or you employ or supervise them, there are responsibilities that go along with their care of patients, such as practice protocols and supervision requirements. So let's review some of that. NORCAL's claims experience shows that allegations in medical malpractice lawsuits that involve advanced practice professionals are directed at both the supervising physician and the APP. One area of liability for physicians is direct liability, and this involves negligent supervision, negligent hiring and credentialing, failure to assume care and delay in diagnosis or treatment. Additionally, physicians who are supervising APPs can be indirectly liable or vicariously liable for the negligence of the APP by virtue of that person being under the physician's supervision. Vicarious liability is applicable when there's an existing employment or supervisory relationship and if the act in question falls within their course of duties. Physicians who supervise APPs can manage vicarious liability by ensuring that those professionals are properly supervised, that they do not exceed the legal scope of practice, and that they are competent to perform their delegated duties. Medical negligence allegations usually include one of the following. First is scope of practice, which includes rendering services beyond their capabilities and acting too independent of the supervising physician, performing an inadequate examination or history, failing to consult with the supervising physician, failing to develop and follow protocols, and improperly monitoring or ordering medications. Let's review a case scenario. A 46-year-old female sought treatment to improve wrinkles, fine lines, and hyperpigmented lesions with laser treatment. The physician had recently trained a physician assistant in his practice to use the laser consistent with the manufacturer's instructions. The physician did not examine the patient nor assess the appropriateness for the specific treatment prior to or at the time of the procedure. The physician assistant performed the laser treatment on the patient's face, neck, and chest using what she believed were the standard settings. The patient, however, suffered deep burn wounds which resulted in scars. And in this case, experts were critical of the lack of a physician examination or at least a consultation with the physician assistant prior to the procedure. They believed that the settings on the IPL laser were too high for the patient's skin color, and had the PA consulted with the physician about skin color and laser settings prior to the procedure, she could have advised and written the laser settings appropriate for this patient in the medical record for the PA to access. So from a risk management perspective, our recommendations are to recognize limitations of advanced practice professionals by reviewing regulations on license and supervisory requirements and scope of practice. Collaboratively develop written guidelines such as protocols, standardized procedures, and delegation of service agreements that address key issues such as supervision and consultation requirements. Review those guidelines periodically as scope of practice or duties may change and there may be a personnel change. I'd like to mention here that if you are using one set of protocols for more than one APP, make sure that it delineates who is capable of doing what. Not all advanced practice professionals have the same skill set or perform the same duties within a practice. Verify competency when hiring new professionals and monitor this ongoing with regular chart reviews, meetings, and observations. Consider limiting the number of visits a patient can make without actually seeing a physician. And understand the supervision requirements and consider limiting supervising physicians to those physicians who are willing to supervise. So we'll move on to nurses. According to a nursing closed claim analysis reported by ECRI Institute, many negligence claims are related to predictable and preventable events. There are various actions and omissions contributing to liability exposure for nurses, which include practicing outside of the scope of the nursing license, improperly assessing and monitoring patients, and failing to communicate. For example, failing to inform or timely inform other healthcare professionals about changes in the patient's condition. In a physician practice, the physician employer bears ultimate responsibility and may be liable for the actions of nurses and other office personnel under the vicarious liability principle, and again, also for direct liability related to negligent hiring and supervision. When delegating tasks to staff, the physician should consider the following. Be sure that delegation of that particular task is consistent with the known standard of medical care. Be sure that it is not prohibited by medical board or state board of nursing regulations for that task to be delegated. And be sure the person to whom the task is delegated is trained and competent to perform the task and that there is an appropriate level of supervision. Physicians should keep in mind that nurses that work in physician practices are not independent practitioners and should function under one of the following levels of supervision. General oversight. This is suitable for traditional nursing functions that do not require direct or immediate physician supervision. General oversight allows nurses to engage in patient care services to ensure safety, comfort, personal hygiene, and protection of patients. And they can also implement appropriate emergency procedures within the scope of their license. RNs are also allowed to perform patient assessments, evaluate data, and develop nursing plans of care. RNs may also implement standardized procedures or change treatment according to written protocols based on a patient's observed status. Written protocols represent an intermediate level of supervision and are meant to guide a nurse's actions in situations where the physician responsible for the patient is not available. And direct supervision is appropriate for complex tasks that require a direct order from a licensed physician, such as the administration of a specific medication or a therapeutic intervention. Orders are based on the physician's judgment regarding the necessary treatment for an individual patient and are carried out under the direct supervision of that ordering clinician. Of special concern is the supervision of nurses performing aesthetic procedures. We've seen in recent years that there has been a marked increase in the number of physicians' offices, regardless of the specialty, offering cosmetic procedures to patients. Many times these procedures are delegated to a registered nurse. In some cases, physicians are being asked to quote unquote supervise a registered nurse who performs cosmetic procedures, as sometimes nurses are establishing independent practices and contracting with a physician to post his or her name on the practice door so that it appears a physician is supervising the nurse. Generally, state laws and regulations promulgated by state boards of nursing and medicine do not allow a nurse to have a private medical or cosmetic practice without any physician supervision. Let's review a case scenario. A 63-year-old female presented to the practice for laser hair removal of her bikini area. When the physician purchased the laser machine, he received a free one-day training session. And when the RN started working for the physician, he did not want to purchase the training session for her because of the high cost. He said they were not using the laser device enough to make the expense worthwhile. There was a sales rep that came to the office and he went through the basic mechanics and the settings for the new RN, but the sales rep was not certified to train laser operators and did not provide thorough training. The RN performed 2 procedures with the second laser hair removal too close in time to the first. In addition to the time factor, the settings were too high, especially given the number of passes the RN made over a very small area. The patient sustained second and third degree burns of the area that were lasered, resulting in permanent scarring and disfigurement. We'll move on to medical assistants now. Competent, adequately trained, and supervised medical assistants, or MAs, can help make a medical practice an efficient organization with a high level of patient satisfaction and quality of care. Physicians sometimes ask us what office tasks can be appropriately delegated to MAs or to technicians. There are some state laws that allow delegation of services that are consistent with known standards of medical practice in the community and not prohibited by the laws and regulations relating to physicians or to other practitioners. Some states regulate MAs very specifically and have detailed statutes outlining supervision requirements and the services an MA may perform, and other states do not. A good resource is the American Association of Medical Assistants, and this is a national professional society for MAs, and they list a number of functions that MAs often perform in the physician offices. This is a good guide. However, if any of these listed functions fall outside of the scope of an MA's practice, according to state regulations, then practices must comply with the state regulations. So if MAs are doing clerical tasks, there's not much of an issue. It's when they perform additional supportive services that it may be of concern. Typically, MAs can perform simple, non-invasive clinical tasks and procedures that they can do safely after training and under the supervision of a licensed physician. Unfortunately, these tasks can be ambiguous, and some of that depends on how well state law and regulations define them. And these clinical tasks are often at the root of practices unintentionally delegating to MAs beyond their scope of service. If MAs perform duties that are supposed to be performed by licensed personnel only, then they are operating outside the appropriate boundaries of their positions. This is considered an unauthorized practice of a profession, and it can be a slippery slope. Sometimes we're asked, what about certified MAs? Even if MAs are certified to perform certain tasks, they're still unlicensed, and the supervising physician may be held responsible for their actions. Lawsuits and claims focus primarily on the physician for not only an MA's negligence, which would again be vicarious liability, but for direct liability in regard to the negligent hiring, training, and supervision. Let's look at a case where a medical assistant gave medical advice to a patient who called the practice. A 60-year-old female was one day post-op for a facelift when she called the surgery practice with complaints of increased pain and a lot of blood in the left drain. The MA advised the patient to take an additional dose of pain medication and to stay off her feet as much as possible. The MA did not ask how much blood was in the drain and how often it was being emptied. She also did not inform the surgeon of the patient's call, nor document the call in the medical record. Later that evening, a patient was admitted to the emergency department for uncontrolled bleeding from the incision site. So the allegation in this claim was inadequate supervision. The MA took it upon herself to give medical advice on her own without consulting the surgeon. So our risk management recommendations are to recognize the limitations and roles of medical assistants and other unlicensed assistive personnel that you may have in your practices, but utilize these professionals to the greatest benefit of the practice while maintaining safe patient care and avoiding liability exposure. Develop job descriptions for medical assistants with precise descriptions for their roles, responsibilities, and job duties. Conduct requisite training of medical assistant responsibilities and job duties to ensure that their roles do not exceed the legal scope of service, and include their scope of service and orientation for all new hires, including the clinicians, so that everyone in the practice is clear on what the MA's role is. Whoops. Be careful how you address medical assistants in the practice. Do not refer to MAs as nurses. This can be confusing to patients as they may ask questions that MAs are not capable of answering. They should always identify themselves as medical assistants. Do not allow medical assistants to provide telephone advice or triage calls. They are only able to screen calls. They're not legally authorized to interpret data or to diagnose symptoms. Develop policies and procedures for how to handle specific signs and symptoms reported by phone, phoned-in lab results, and scheduling any other tasks that the MA is being assigned to do. And verify that injections or medications are only given by a physician or APP order, and ensure that the office system for prescription refills reflects proper supervision and does not allow MAs to exceed their scope of service. MAs under the direct supervision of a physician or APP should only call in routine refills that are exact, patient-specific, have no changes in the dosage levels, and have been authorized. Okay, so moving on from supervision and the healthcare team, we're going to talk about informed consent. And there will be plenty of time at the end of the program for questions that you may be thinking of now in regard to these topics that we're reviewing. So the most important piece here with informed consent is that clinicians and patients communicate, that they exchange information so that the clinician understands the patient's symptoms or problems, and the patient in turn is told what can be done to further investigate or treat the condition in the proposed plan of care. To initiate the treatment process, the clinician must have the patient's consent. That is, the patient must voluntarily agree to cooperate with the plan of care. There is a difference, though, between the general consent for treatment and informed consent. When a patient presents for an appointment with a physician, the patient implies consent by appearing for the appointment and undergoing an examination. For a variety of reasons, however, many forms of treatment, including surgical or invasive procedures, require the patient's informed consent. To satisfy the requirement that a patient's consent is informed depends in part on state law. For example, some states require specific informed consents for certain procedures, and in part on what a reasonable person would need to know in order to make a decision. Generally, the physician is responsible for ensuring that the patient has been given an explanation of the proposed procedure or treatment and its risks and benefits and any alternatives, has had a chance to ask and get answers to questions, and then the patient has then agreed to the proposed care. It's also important that this information is communicated in informed consent forms are written in plain language. It's important to consider the health literacy of your patients, and we've got a couple of resources that I'm happy to share with you. The AMA has a health literacy video that can now be found on I think it's the AMA Foundation's YouTube channel. And if you type in health literacy AMA, you'll be able to pull that up on YouTube. And the CDC has a publication titled Everyday Words for Public Health Communication. So these are both great resources for addressing health literacy in your practice. We would recommend that physicians and surgeons who perform aesthetic procedures develop customized informed consent forms for all the procedures that they do. NORCAL has an informed consent resource document with a sample form template in a checklist format to ensure that you and the patient cover and document all risks of the procedure. And this form is available on our policyholder website, My Account. Here's a case example. A 26-year-old female presented to a plastic surgery practice for a rhinoplasty consultation. She showed the surgeon a picture of a popular celebrity and stated that she wanted a nose just like the celebrities. The surgeon guaranteed that he could give her the exact same nose. He further stated that complications for this procedure are rare and she should heal rapidly with very little downtime. The informed consent discussion consisted of all the benefits and little to no discussion of risks or alternatives. After this discussion, the patient was excited to go forward with the procedure. During the procedure, the surgeon determined from the structure of her nose he could not take enough bone to give the patient her desired look. The patient was unhappy with the result and sued the physician, claiming that he guaranteed he could give her the same nose as the one in the picture she showed him. She further claimed that her nose looked worse than it did prior to the procedure and that the surgeon ruined any chance of a revision to improve it. I'm going to read another case example, and this also involves a cosmetic surgery procedure, but I want to point out that the principles of the informed consent process apply to any care setting where aesthetic medical services that have risks, benefits, and alternatives are offered. In this case, a 56-year-old male presented to a cosmetic surgeon's practice for a facelift consultation. The surgeon took a medical history from the patient and found that he was a heavy smoker. She advised the patient that he needed to stop smoking before she would do the surgery. 2 months later, the surgery was scheduled and performed without verifying that the patient had stopped smoking. 10 days post-op, the incision sites did not seem to be healing. And then 3 weeks later, the skin at the incision site started sloughing and signs of infection were present. When asked if he quit smoking, the patient stated he had not. He stated he did not know why he had to stop smoking, and everyone was always telling him to stop smoking, so he didn't take it seriously when the surgeon told him to stop. The patient sued the surgeon for improper technique and failure to warn him about the impact smoking would have on the healing process. I'll review some risk management recommendations for the consent process, and I want to stress that it is a process. It's important to develop an informed consent process, including 4 essential elements: discussion, education, documentation, and a form. It's important to discuss risks, benefits, and alternatives. Include risks that may be unique to the patient due to previous medical history and comorbidities. For example, there may be a patient with diabetes that may have delayed healing. Explain to patients why they need to stop smoking or stop taking certain medications or supplements. Don't assume that they will stop without knowing why. And don't guarantee results. Be transparent about the risks and downtime required to heal. Provide educational materials that might help the patient better understand the proposed procedure, and document any of those educational materials that you do use. Also document any relevant specifics of the discussion. Include questions that the patient asked and how you answered them. Do not delegate the informed consent discussion. Confirmation that the discussion has taken place and witnessing the signing of the form can be delegated, but the practitioner performing the procedure or the treatment is responsible for the informed consent discussion with the patient. So that's kind of a big topic. I touched on some of the key risk issues, but we'll move on now to the next topic of medical record documentation. So whether electronic or paper, appropriate, consistent, and accurate medical record documentation cannot be overstressed. Let's take another quick poll. Are you confident that your documentation practices would significantly help defend your care in the event that you were sued? And Shirley, I'll let you open that up.
Okay, here it is. I'm working on it. There you go. So I was waiting for the responses to come in, and it looks like we're still collecting a few. And I'm going to go ahead and close this poll, and here are the results.
Good. It looks like the majority of you are fairly confident that your documentation practices would significantly help defend your care. That's great to hear. There are some that aren't sure, and some say no. So we do have an opportunity to kind of review some recommendations that might increase your confidence in regard to your documentation practices. Let's start reviewing the purpose of the medical record. And first and foremost, a complete medical record is a communication tool. It's a tool that promotes quality patient care by providing a comprehensive patient history and facilitating continuity of care among members of the healthcare team. The medical record demonstrates compliance with standards of practice and clinical practice guidelines, policies, regulations, that kind of thing. The record also supports reimbursement by justifying treatment decisions. The record substantiates quality initiatives, including any meaningful use or MIPS criteria you're trying to capture. It also enables peer review. And lastly, the record is used as a defense tool against allegations of medical negligence. From a risk management perspective, a complete record can help prevent and minimize the potential adverse consequences of a malpractice claim. So I'll touch briefly on these critical elements of a medical record. Your documentation should be an objective statement of the facts with your findings as well as your assessment and plan. Your charting should also accurately reflect the patient's subjective complaints or relevant statements. Use quotation marks for any patient statements that you do include. Avoid editorial comments and opinions, as well as interjections and assumptions for which there is no basis. And limit your documentation to anything that affects the care of your patients or decisions regarding the care of the patient. Entries should be factual, clear, concise, and credible. They should be meaningful and relevant and show a clear thought process. Avoid vague, ambiguous, and contradictory statements that could be open to interpretation. And be aware of the mechanics of your documentation. And mechanics are those things that translate your thoughts into words, including your spelling, your punctuation, grammar, capitalizations, and sentence structure. The medical record should also be complete. All supporting documents and documentation need to be present in the medical record, and they should be completed timely, ideally contemporaneously with the patient's visit, or at least by the end of the day. The record should also be chronological, meaning dates should follow in order with appropriate documentation from one visit to the next. It's also important not to pre-chart, meaning don't document ahead of time before the event or the episode of care occurred, excuse me. And I'll show you a case example that highlights this in a moment. As you know, electronic health records are date and time stamped. So every time a record is accessed, it is captured in the metadata. Document the disease process by completely documenting all signs and symptoms, results of physical exams and assessments, and tests and procedures. The treatment should be clinically appropriate for the diagnosis, and the record should reflect that. It's important to keep these elements in mind, as a connection is often made between the quality of the medical record and the quality of patient care provided. As I would imagine, most of you are using an electronic health record system now. I wanted to touch briefly on problems that may occur with EHRs. One problem is that there may be inaccurate information from auto-populated fields from entries that are carried over or default entries, which may not apply to a particular visit. And these entries may not always be reviewed for accuracy. In addition, sometimes there may be a limitation on free text or fields to enter comments, especially in documentation templates that have checkboxes for systems with those within normal limits baselines established. If a patient falls out of the within normal limits, there should be a narrative documentation entry to support your assessment and findings. EHRs at times can be frustrating. We all understand that. And for example, there may be numerous steps to get to a particular screen or field. And shortcuts can become tempting when there's frustration with accessing the information. The copy and paste feature can be particularly problematic. There could be fraud issues in regard to billing associated with copying and pasting or pulling forward of information that's not applicable to that episode of care. I've even seen situations where documentation, for example, a procedure note, is copied and pasted from one patient's record to another. In these situations, patient safety is also compromised, as there is an increased risk of a medical error if inaccurate information in the record is relied upon. Simple errors that can be avoided can make the physician appear incompetent and uncaring. And juries will typically not be sympathetic to workarounds and shortcuts, such as copying and pasting, especially when an error occurs that causes patient harm. If your practice allows copying and pasting, consider developing a policy to possibly allow demographics, medications, allergies, and problem lists to be pulled forward or copied and pasted, as long as information is reviewed with the patients on each visit and things that are no longer applicable are updated. You should consider doing chart audits to monitor for inaccurate information. And we've seen some practices use their billing staff to look out for copying and pasting issues. As they're looking through the record for, for billing purposes, they should be able to see if one chart entry is exactly the same as another. If you do find incorrect information in a record, you should remove it from view as soon as possible to prevent this from getting replicated, sent to other providers, billed for, etc. The bottom line is that creating a policy to prevent copying and pasting is unrealistic, and it can result in additional workarounds that may be detrimental. However, we should try to limit that feature. Okay, so here's a case scenario demonstrating poor documentation practices. A 33-year-old female presented for buttock fat transfer, back lipectomy, and liposuction of her arms and thighs. After surgery, she was transferred to the recovery room where she developed sudden bradycardia. She continued to deteriorate and CPR was administered. The patient was transferred to the hospital and later died. The autopsy revealed that she had an iatrogenic injury to her iliac artery. It was later discovered that the anesthesiologist had completed the post-anesthesia evaluation before the surgery had even begun. In addition, the surgeon had completed the discharge note, and there was also documentation in the record indicating someone had witnessed the patient sign the discharge instructions. So there was obviously some time-saving shortcuts that negatively affected the credibility of the record, and that could drastically affect the defensibility of the claim. So don't pre-chart. So to summarize the key risk management recommendations regarding documentation, it's important to review your documentation practices for those critical elements of completeness, accuracy, credibility, and the others that we discussed. Document timely, ideally contemporaneously with the patient's visit. Consider a standardized documentation process for everyone who documents in the medical record, such as a SOAP documentation format, the subjective, objective, assessment, and plan format, to gather information for basic office visits. Consider conducting periodic chart audits. You want to ensure that each visit note contains accurate information and reflects details of what actually occurred during the visit. Watch for inaccurate chart entries in the EHR as a result of carried forward information, template defaults, or checkboxes. And create documentation policies and procedures for how to do corrections, alterations, addendums, or late entries. Also for copying and pasting or carrying forward of information, as well as access and release and retention of medical records. So we touched on several things today, kind of addressing the key risk issues here. So final thoughts going forth are to use that information you learned to assess your own practice for those key risk issues that may contribute to professional liability claims, and to apply some of those risk management recommendations to support patient safety and increase defensibility in the event of those claims. And this actually concludes the content portion for today's webinar, but we've got time for some questions, and I'll hand it back over to Shirley to review how to enter those questions again, and then she can also review how to get CME credit for today's webinar.
Thank you, Jody. Yes, just before I go over how to get CME credit, I just want to review how to enter questions. For those of you who may have arrived a little late, there's a control panel, and you may notice a column of icons on the upper right side of your screen. And if you click on the arrow at the top of the column of icons, you'll open up the control panel. And there, if you look down, you'll see that there is a section for questions. Just open that up, and in there you can enter your questions for Jody. Okay, so how to get CME credits. Let me go ahead and advance the slide. Okay, so there will be a email sent to you, and it'll be sent to the registered attendees, and it will contain a link to the survey in which to claim credit. Please be sure to enter your name as you would like it to appear on your CME certificate. And also give us a day or two to actually get those out to you. We will email them to you to the email address that you provide. If you are watching this with a group, please note that only the registered attendee will receive the email, so that person should then go ahead and forward it on to the other members of the group. If you're sharing a registration link, just know that only the registered attendee also will receive the email, and so you'll want to contact that person to get the link for the attestation survey. All right, so it looks like we've had a few questions come in, so I'm going to go ahead and hand this back to Jody.
Sure. So just there are a few questions asking about a handout for the slides, a copy of the slides, and Shirley did put the slides in a PDF format, and they're available as a handout on your control panel. There should be a button for handouts. If you click on that, there should be a PDF of all of the slides that we went over today. And if you can't see that, you can let us know. We'll be happy to send you a copy. So we have a question, and this was actually, I've had this question a couple of times. This particular physician is in Illinois and has not been able to find any specific scope of practice regulations for medical assistants, and that's not uncommon. I'm in Missouri, and Missouri's regulations are silent on the scope of service for medical assistants. So I think Illinois may be as well, but a good place to start to see if there are any regulations in your state that govern what they can and cannot do is to contact the state medical board, because oftentimes if there is anything regulated, it's going to be there in regard to supervision of those professionals. So I would start by looking at the medical board and reaching out to them if maybe you're having a hard time locating something, and again, it may just be that there's nothing there. California, on the other hand, has a lot of regulation and rules about what an MA can and cannot do. So it is oftentimes very state specific. So there's a question about what are estheticians, let me scroll back up here, classified under. Would it be an MA or something different? I mean, I believe estheticians are licensed, but their license would have a scope of practice for what they can and cannot do. So you need to be familiar with what it is that they are allowed to do. They're not going to be allowed to do, certainly the things that an RN or an LPN or other licensed healthcare staff in your office can do, but they would have specific things that they can and cannot do, I would imagine. So looking again at your state, the state board of professional registration for these healthcare members would be the first place to start. Let me look here, and I'll just mention that if I can't get to all of your questions right now, we will have these, and I'll have who it was that sent the question to us, and I can respond by email. Let me look through here. Okay, yeah, there's some questions about a standing order for cosmetic laser procedures. I can look into that a little bit more to see if there's some standardization with maybe, some professional membership groups or things like that that would be helpful to pass along. And I can look and see if there's something I could share with you after this. Sorry, I'm just kind of reading through here. Okay, I've got a pretty long question. I may follow up on that one after the webinar. Is it in regard to supervising and kind of getting some of those steps in place to make sure you're managing that correctly? So I will follow up with that attendee directly. Okay. I think that's all I see at this time, but if you have any other questions, let me advance my slide here. I don't know if Shirley, if you got mine up or if I'm using yours, but my contact information should be on the screen right now. So feel free to reach out to us with any questions, either by the email, which would go to our department and would get to me, or to our phone number of our department, and we'll be happy to follow up with anything that you think of later as well.
Thank you, Jody.
Okay,
And
yep, Shirley, I'll turn it back over to you.
Okay, thank you. Well, thank you everyone for participating in today's webinar. Just to let you know, this webinar was recorded and will not be up immediately on our website, but it will be up eventually on our policyholder website, My Account. And you can look for it there in order to view and also to obtain CME credit. If you have any questions, again, just contact us here at the Risk Management Department or through email if it's not urgent to risksolutions@norcal-group.com. You can generally expect to receive a response from the email within 24 hours. And if you contact us by phone, we'll connect you directly to a risk management specialist who is on call. So thank you again. Have a good rest of the day today.
Yep.
Jody, thank you for all your effort on this presentation.
Sure. And yes, thank you. And thank you everyone for attending, and we're happy to help.
I'm going to go ahead and
Shirley.
close. You're welcome. Thank you. I'm going to go ahead and close the presentation.
Everyone.
Bye.